Abdullah.
Yes, please, we can see your screen.
Okay. Good morning, everyone. My name is Elizabeth Odu, as introduced. I'm presenting on medical nutrition therapy for hypertension. By way of outline, we'll have a brief introduction, look at risk factors, the medical nutrition therapy for hypertension, the DASH diet, and then conclude. Hypertension is high blood pressure, which is higher than 140/90 mmHg. Patients who have elevated blood pressure should have their blood pressure confirmed using multiple readings, including measurements on separate days to diagnose hypertension. So when it comes to the diagnosis of hypertension, one measurement is not enough. It should be done consistently to confirm the diagnosis. There are several risk factors that would lead to hypertension, including obesity, high sodium or salt intake, increase in age, alcohol intake, genetics, pregnancy, among others. When it comes to hypertension, the way to prevent or lower high blood pressure includes the dietary approaches to stop hypertension, which we know as the DASH diet, maintaining a healthy weight, staying physically active, avoiding or limiting alcohol. So we'll look at the medical nutrition therapy for hypertension. As dietitians, we use what we call the nutrition care process, which I'm sure we are well abreast with. And the nutrition care process consists of the nutrition assessment, which has the body measurements, biochemical data, clinical history, diet history, and all other information that are necessary. Then you come to the nutrition diagnosis, which looks at what nutritionally may be leading to the problem that we are seeing with the hypertension in this case. Then nutrition intervention, what practical step the dietitian should put in place to resolve the nutrition problems that are identified. And then you continue to monitor and evaluate the situation to ensure that you're achieving your targets that you set for each patient. So by way of introducing DASH diet, this dietary approaches to stop hypertension study evaluated the effects on blood pressure of 3 dietary patterns. One, a controlled diet that was similar to the traditional American diet. The second one was a diet that was high in fruits and vegetables only. And then the third one was the DASH diet, which is higher in fruits, vegetables, low fat dairy products, and lower in total fats, saturated fats, and cholesterol. Both the diet that is high in fruit and vegetables and the DASH diet led to a reduction or lowered blood pressure. However, it was noticed that the DASH diet lowered systolic and diastolic blood pressure by 8 and 6 mmHg respectively. The diet was effective in all subgroups, which included people with hypertension and others who didn't have hypertension. So when we talk about the DASH diet, it's made up of legumes, whole grains, lean meat, fish and poultry products, fruits, vegetables, and it's very low in sugar and sugar-sweetened beverages, saturated fats, trans fats, and cholesterol. The DASH diet also has good amount of unsaturated fats from food sources like nuts and other foods. So as one of the components of the DASH diet, they looked at the dietary sodium intake. And it was found out that though blood pressure responses were varied in the studies that they conducted, different levels of sodium were used in the DASH diet with people who had hypertension or not. But it was found that the lower the sodium intake, the greater the lowering of their blood pressure. So the effects were greater in hypertensive individuals, African Americans, and women. And we know that African Americans have a higher risk of hypertension. But this study found out that the lower the sodium intake, the greater their benefits. Then compared to the control diet, which was high in sodium at 3.6 grams, the DASH diet with its low sodium level at 1.2 grams, which is approximately half a teaspoon of salt, led to a mean systolic blood pressure 11.5 lower in participants with hypertension, and then 7.1 lower in participants without hypertension. The immediate diet had an effect between those of high and low sodium diet. So that even buttresses the point that whether you have hypertension or not, the DASH diet is able to help to bring your blood pressure to a better level. So let's look at practical tips as dietitians we can use in reducing salt intake in a diet. We want to encourage patients or clients to read food labels so that they know how much sodium there is in there. We want to encourage them not to add salt at table if possible. And then it is also possible to cook foods without adding salt, especially with carbohydrate foods like pasta, yams, rice. You can cook all of that without adding additional salt. Vegetable cereals, salt can be omitted without losing much of the flavor in there. You also want to encourage patients not to take too much of meats and fishes that are high in sodium. If possible, avoid them, especially if they have high blood pressure. Let them avoid these ones unless with salted fish and salted meats, some people like to soak them for many hours where you are removing as much as possible the salt that is in there. Otherwise, encourage them to avoid them. Then if it comes to canned foods, rinsing them under water for 1 minute is enough to remove great amount of the sodium that is in there. And you also want to encourage patients or clients to use herbs and natural spices like the nkitty, rosemary, white pepper, and black pepper powders and all of that instead of adding actual salt to the food. Another thing is to limit fast food because we know these are also very high in sodium. Then once they eat fast food for one of their meals in the day, you want to caution them to be careful about the other food choices they make the rest of the day. Now looking at dietary fiber, a meta-analysis of 24 randomized placebo-controlled trials were done to estimate the effect of fiber supplementation on blood pressure. Now it was realized that fiber supplementation lowered systolic blood pressure and also the diastolic blood pressure as indicated. Reductions tended to be larger in older persons and hypertensive populations than in the younger ones who had normal blood pressure. But in the case of dietitians, what we recommend greatly is getting these fiber from natural sources like the fruits, the vegetables, fruits like oranges, mangoes, bananas have different types of fiber, whether soluble or insoluble ones. Whole grains have good amount of fiber. Legumes and many other food options have good amount of fiber. So it might not be necessary to take fiber supplements to get your recommendations on fiber intake. We want to get them from natural fruits and vegetables and healthy sources. Now, when it comes to physical activity, two meta-analyses have demonstrated the beneficial effects of exercise on blood pressure. The first one showed that just by walking reduced resting systolic and diastolic blood pressure levels in adults. The second one, which included 54 randomized clinical trials, aerobic exercises reduce systolic blood pressure at an average of 4 mmHg, and then diastolic blood pressure at 2 millimeters mercury, irrespective of the changes in body weight. Thus, increasing the amount of low to moderate intensity physical activity, 30 to 45 minutes, most of the week, like we always recommend, five days at least in a week, is very important to help, together with other lifestyle strategies, to bring down the blood pressure nicely. Potassium is a key nutrient that helps in nerve and muscle functioning and also the heart functioning, knowing that the heart is made of a lot of muscles and nerves. A meta-analysis found that high dietary potassium intake may help prevent and control hypertension. So we encourage our patients and our clients to eat foods that are rich in potassium, like banana, coconut water, legumes, and nuts have good amounts of potassium, including dark green leafy vegetables and all of that. So we want to encourage our clients and our patients to eat from these sources so that they can meet their potassium need and thereby help to control blood pressure. Now, when it comes to calcium, population studies have found no significant relationship between calcium and the prevalence of hypertension. However, a meta-analysis showed a small reduction in blood pressure with the use of calcium supplements. That is not to say that we are recommending calcium supplements. We recommend that our clients or our patients take foods that have naturally abundant calcium sources like milk and legumes, including many other foods as shown in the picture. Another key nutrient is magnesium. In most clinical studies, magnesium supplementation has been ineffective in altering blood pressure, possibly because of other confounding factors that may be present and then the short duration of the study. However, magnesium is still a great nutrient that is needed for general healthy living. So you also want to include that in the diet for a hypertensive patient. When it comes to weight loss, weight reduction should always be considered when it comes to the management of blood pressure. Research has shown that a loss of 1 kg in body weight has been associated with a decrease in blood pressure of 1 millimeters mercury. So that's a very positive one. It can also help to set the target of weight loss and then what direct impact you should be seeing on the blood pressure. So by way of summary, Lifestyle modifications for hypertension management and prevention include stopping smoking, which is also another high risk factor for hypertension, maintaining a reasonable amount of body weight if needed. You need to lose weight, reduction in sodium intake. And let's remember that sodium intake is not just associated with salt, but many other foods that may have great amount of sodium in there, like artificial spices and all of that. The reason why we encourage them to have natural spices, which do not have as much high amount of sodium in there. Increasing physical activity greater than 30 minutes most of the days, aerobic activity is a great way of helping to manage and prevent hypertension. Then you also want to have adequate amounts of potassium, magnesium, and calcium by eating fruits, vegetables, and low-fat dairy foods. You also want to reduce intake of dietary saturated fats and cholesterol from foods that are high in fats like meat and all of that. Thank you. These are my references. Hello. Hello, Abdullah.
Okay, sorry. Thank you all very much. Sorry about the technical challenges. Thank you very much. I think we have a few questions. Let me just go through. Somebody's hand is up. Mabel, please, you can go ahead to unmute yourself and ask your question. Hello, Mabel. Mabel, you can kindly unmute yourself. All right, if Mabel is not ready, someone had a question in the chat box. Okay, just someone said they had. Please, if you have a question, you can unmute. Slide, please, you can unmute and ask your question, please.
Okay, thank you. I hope you are hearing me, everybody.
Yes, please, we can. Go ahead.
Okay. So, in fact, my question goes for not only the Audi, but all of us. In terms of alcoholic intake, so I read a study somewhere that now there's a zero tolerance for alcohol. So that means that we shouldn't even advise that regular recommendation of 1 bottle for a man and then 2 bottles for a man and a bottle for a woman. I want to know whether as dietitians, that is what we are doing. I want to know about it. Because with the research I read, they were saying that most of the foods that we eat give us the alcoholic percentages that we need for our body. So there's no need to add more. So I want to know what we all think about the alcoholic intake. Thank you.
Thank you. Adi, please, would you answer? Would you take in more questions before?
Okay, I think we should answer the questions. Bye.
Okay, sure.
Abdallah, more
Yes,
questions.
please.
Allow the speaker to respond to them.
Hello.
Adi, please,
Hello.
you can go ahead and answer.
Okay, so the current recommendations are that no alcohol at all. But of course, as dietitians, we never for once recommended that our clients take alcohol. Previously, it was stated that some amount for men and women. But if the person is not taking alcohol, the recommendation is not to start. If they are taking, we encourage them to gradually decrease and wean off alcohol altogether. So that's a way to go.
All right. Adisla, are you okay with that?
Yes, I'm okay. Thank you, Audi, Lizzie.
You're welcome.
Okay. There's a question in the chat box. The question reads: the physical activity recommendation. Okay, so the physical activity recommendation is not clear to me. WHO recommends 150 to 300 of moderate physical activity and 75 to 150 minutes of vigorous physical activity per day. So this person is asking something, if you can clarify to make it clearer about the physical activity recommendations.
Yes. So if you listened, you would have noticed that the recommendation I read was 30 to 45 minutes at least 5 times in a week. So if you're considering the minimum of 30 minutes 5 times a week, that's about 150 minutes in that week. So these are the low and high values. And then if it's moderate physical activity, of course, it's going to take a lot more longer than if the physical activity is vigorous and intense. But we must know that when it comes to hypertensive, hello.
We lost you there.
Okay, so I was explaining that. Hello, Abdullah. So I was explaining that the 150 minutes are stated here by Samson. If you multiply 30 minutes by at least 5 times a week, you would get 150 minutes for moderate physical activity. So that's the minimum you should encourage the clients to do. Now, if the exercise or physical activity is intense, the duration is shorter. But when it comes to hypertension, we have to be cautious how vigorous their physical activity is so that we don't lead them to do physical activities that will eventually give them palpitations. So there should be a fine balance between whether the physical activity should be vigorous, intense, and then the duration. You always want to make it individual for that patient, even though this is the appropriate recommendation stated.
All right. Thank you very much. So, individualized care plans work with your physio to get an appropriate physical activity ready. I think RD Mavis, if I'm not mistaken, has a question. The question is, please, what is the role of caffeine in high blood pressure? Example, intake of energy drinks. RD Lizzie, please, that is the question. What is the role of caffeine in high blood pressure? Example, intake of energy drinks.
Okay, so some studies have also shown that caffeine directly increases the blood pressure of some clients, but there have been other studies that have shown that some individuals do not even react to caffeine at all, especially those who have some genetic predisposition that makes them break down the substances that are able to increase blood pressure when caffeine is taken. But generally, the recommendation is that don't encourage clients or patients to have caffeine-rich drinks, coffee, and all of that, just to be on the safer side.
All right. So we have RD Lady's hand up, then another question in the chat box. RD Lady, please go ahead.
Yeah, so Lizzie, a great job. I think when we thought we were entering into the deep, you were done. It was great. It was great. All right, so I wanted to just add to the exercise bit. The RD Akabonge's the recommendation is the 150 to 300 is the general healthy activity recommendation, and for the rigorous as well. So it is for us to be on the safer side, especially those who are not newly diagnosed hypertensive, but they've been hypertensive for a while. It's always important to run every decision in terms of exercise by the patient's doctor. Very important, because they might have told them something even in the consult room before they come to us. General exercise is good for our clients, but when the person has a condition that too much exercise may cause trouble, it's always important, like Abdullah said, I would say, speak to the physician and the physio if the patient has a physio. Yeah, thank you.
Thank you so much, RD.
Thank you very much, RD, for that contribution. I think there's a follow-up question concerning the caffeine, but the next question is, what about prolonged lack of sleep? Any impact on high blood pressure? Brown cocoa drinks. Is there anything you would like to add, Alice?
Yes, I think that was significantly missing in my presentation. Stress or lack of sleep can also negatively impact the blood pressure. It can increase the blood pressure. So that's, you want to have adequate sleep, rest, so that the blood pressure is controlled, especially again in people with hypertension. And even in normal persons, if you are under so much stress or not sleeping enough, your blood pressure can increase.
All right, thank you. I believe we are well answered, RD Mavis. There's a question from an RD, says that thanks for the presentation about rinsing of canned foods. Can you elaborate on it? He's asking, if he has canned tuna, how does he go about rinsing the canned tuna to take care of the sodium and the other things we have mentioned? How do you rinse the can?
Okay, that's pretty easy. You just the canned tuna may be in brine, which is salt water, or whatever it is canned in. You open the can, pour it in a sieve under running water. You just keep the water running, and then you rinse it, and that's it. You're going to lose a lot of the sodium by just rinsing the tuna that way. Even if you taste it, if you have tried it and it tastes it, you clearly see that yes, most of the salt would have been taken out in there. Otherwise, you can also recommend that they limit the intake altogether.
All right. Thank you very much. Rita, hello Rita, please you can unmute and ask your question.
Yeah, thank you very much, Boss Elizabeth. Yeah,
Start with a few real first.
my question was about the canned foods, and I think it has been partly answered because you realize that most of the time when people buy these kind of foods, they wash and then open it up, they pour all the sauces, the sauce plus the fish inside it. So when you say you should rinse it, how are they going to do it? Do they have to discard the sauce? The sauce.
Yes.
So are they going to discard the sauce, or how are they going to do it so that to minimize the sauce content?
Yes, please. So when it comes to, for example, let's say mackerel in tomato sauce, the tomato sauce with the mackerel have high amounts of sodium. So you don't want to encourage them to have that added to their food. And even the fish itself can also be rinsed again to reduce the sodium intake there. So the stock around the fishes or whatever canned foods you have will have good amount of sodium in there as a preservative. So you don't want to encourage them to add that to their food if they insist on taking canned food. Then again, you also want to look for some of these canned foods that have way low amount of sodium in there. They are very good tunas out there in the Ghanaian shelf now. It's clearly indicated low sodium, and then the amount of sodium indicated on the pack. So yes, you don't encourage them to add the sauces, attach the food in there.
All right, thank you very much. Howdy, Mavis. You have your hand up. Do you still want to ask a question? Howdy, Mavis. If yes, you could just raise your hand again, and then I'll call you. Okay, great. So please, you can unmute and then ask your question.
Thank you very much, Abdullah. Elizabeth, great presentation. Love it. The reason why I asked in regards to lack of sleep is that I've noticed this trend amongst my population. You have these truck drivers who are now consuming large quantities of energy drinks in an effort to stay awake during long haul trips. And it's leading to high blood pressure. I've also noticed it in newly given birth mothers who are unable to sleep, which is causing a lot of issues with what appears to be randomly high blood pressure. And when they are allowed to get rest, most of the time the high blood pressure situations come down. I've had several where some were long distance truck drivers who were using energy drinks as a means to keep themselves awake, and as a result were triggering high blood pressure symptoms that were not actually related to food or to any of the other parameters that were obvious. And by probing, we realized that these situations of lack of sleep were being triggered by high consumption of caffeine as an effort to try and stay awake, which led to inadequate sleep patterns that were being developed in these two scenarios. So I'm just bringing it up as a word of caution and to just alert people when attempting to find out why individuals' high blood pressures are up. It may not be the obvious sodium per se, but it may also be in conjunction with the sodium plus lack of adequate sleep that is also triggering. Thank you very much, Liz. Great presentation.
Thank you so much. Great input.
Thank you very much, Adi. That's a wonderful contribution. All right, so Adi, Liz, I also have a question. I just want to know, what is the science saying about management of hypertension and the use of supplements in terms of these natural supplements, is there any evidence that is showing that it's working? I think I've heard a couple of people trying different, like turmeric, seeds, and other things that is out there. Is there evidence, clear evidence showing that these things improve or help manage the blood pressures of an individual?
Okay, so when you say supplements, there are different kinds of supplements. When it comes to let's say fiber supplements, of course, I read one that showed that it can help in the control of hypertension. But can we not get fiber if we are eating a balanced diet? If you are eating the DASH diet, are we not getting enough fiber in there? That's the question we have to ask. So if you are getting a balanced diet and you're following the DASH diet, then of course you wouldn't need, there's no indication for supplementation because you're getting it from there. The issue about supplements now comes when people are not eating well and want an alternative to substitute so that they may not have deficit. Then they want to consider some of these supplements. If you talk about turmeric, cinnamon, and many of these are things that can actually be taken as part of your balanced diet. So we want to add some of these spices to our everyday eating, our everyday food, so that it doesn't become something like, oh, unless you buy the supplement, you're not going to get it. If all these food substances that are used, interestingly enough, most of the supplements are also made from food substances. So if you're getting the food right, then there's no indication for supplementation.
All right. Okay. Thank you very much. Is there any other question? Is there any other question from anyone? Any contributions? All right. Adibadu, please go ahead.
Yes, I want to ask our colleagues, do you hear or do you get your clients talking about the intake or swallowing of garlic pills as a means of curbing or reducing their pressure levels? Do we face that in our consulting rooms, as some of us do? Garlic capsules.
Please, anyone who wants to comment on that can just raise their hand out on YouTube. Any experience with garlic capsules being taken by our clients with the focus of reducing their pressures? Any experience? Anyone? Anyone with the experience of garlic capsules or garlic pills? Okay, is it that we are not getting those kind of patients, or we are getting the very good ones? We are not getting the people who have read online and are coming to try things and question you. How do we do? It looks like no one has that experience. Okay, someone says for cholesterol management, they've seen someone like that for cholesterol. Okay. Anyone? Anyway, did you have a follow-up to your question before I take the next person? Okay. Please go ahead and return. Anyway, you can go ahead.
So yeah, so I just wanted to know if other people have been actually including that in their management, and how it's panning out because in and out and on and off, I get people saying, "Oh, I've been swallowing garlic. I've been listening to the adverts and I've been using it." When you ask them, they said they don't know. They haven't taken it for that long, so they don't know whether it's helping. Some will say it helps for a while, then it doesn't help again. So maybe if we don't have much data on that, I've seen Dr. Ntifo, Dr. Anderson online, and Divine as well. So we may look at it in our some of the research that some of the students may do to give us if there is any link between that, because I hear people say they take it and it helps. Yeah. Thank you.
Okay, thank you very much. So the challenge has been thrown to us. Let's try and see if we can get data on some of these things to help us forge the future trends and help us know what we can do in future. All right, how do you define? You had a question. If you are still willing to ask, then you'll mute, you can go ahead.
Okay, I hope you can hear me now.
Yes, please, we can.
Thank you very much, and thank you for the presentation, Madelizi. I wanted to ask something. I think I'm just seen also something in the chat box that also comes to what I want to ask. I was looking at, as in it's not only to Madelizi, maybe if anybody also has, wants to look at it from another perspective about exchanges when it comes to this rinsing issue. Just like when you have diabetes, sometimes we say, okay, so instead of giving the person sugar, look at this, calculate how much would carbohydrates and all those things. I'm looking at having somebody, maybe sardine, maybe something in mackerel in tomato sauce and all that, looking at rinsing it so that we'll reduce the amount of sodium present. I don't know what we think about looking at, okay, so I'm preparing soup, I'm preparing stew. The recommendation for sodium, let's say I'm looking at 1,500 milligrams, whatever amount I'm looking at. Then I consider, instead of rinsing the mackerel, which some clients may have issues with, or rinsing the sardine and tunas, as I see somebody saying about in omega-3, fatty acid being present and all those things, rinsing them and losing them. Can we read the labels and look at it and say, okay, there's the amount of sodium present in there, give or take, let's say 500 milligrams. So instead of putting this amount of salt inside, I take that one out. And instead of rinsing this tuna or sardine or mackerel, the tomato, everything out, which I probably would need for this and all that, then I replace it. I don't know what we think about it. We're looking at alternatives for our clients so that they, in trying to holistically help, this is to all of us what we think about that. Can we consider that so that we help our clients holistically? If maybe somebody has challenges with probably rinsing tomato, I want to buy the whole mackerel, I need the whole tomato, yes. So that's what I'm doing.
Thank you very much. It's a very good question or point. Does anyone have any contribution to that effect? Anyone, please? So it's sort of, yes, please, you can go ahead, Adi.
Okay, so that's a beautiful idea too. You know, the issue about rinsing it does not mean that you have to rinse every single canned food that you are adding to it. It's a way of reducing the sodium. It doesn't mean that it is the only way to go. So and then again, you want to look at the total amount of sodium you're taking in the day. So it's not just got to do with one specific food ingredients or components. Look at it holistically and then find creative ways of reducing the sodium, and I think that it should be fine.
Thank you. Is there any other contribution to that effect? Adibedu. Adibedu, you can go ahead to.
Yeah, yes. I think Safiano's hand is also up, so maybe when we are done. All right, so the Adi Divine, I greet you. The what I was going to say was what Lizzie used to summarize what her comment, that we must be innovative. So just as we did with the diabetes, that the amount of the carbohydrate must be rated far above the source. So if we are going to, we have come to the conclusion we are using 1,500 milligram sodium or half teaspoon, depending upon how your discourse with your client go. So if the person is not an avowed salt taker, and the person actually, when you look at how he or she has been eating, the person eats most of the meals from home, and you can use a lot of other strategies, including asking the person to cook all the meals without salt, and measuring their daily salt intake in their sprinkler for them, and encouraging them to use it as and when they want, whichever food they want to add a bit of salt. That could also be another way. Especially this is done for many of the uncontrolled hypertensives who really are not able to measure and manage their salt at all. So that is also another way. Or if the person wants to use sardine and it doesn't have money for the fresh sardine and it's the canned one, we as dietitians know how much sodium is in one can. So we can easily calculate it and factor it into the person's meal plan, even if the person decides not to rinse it. So it's not a straitjacket, something we may have to do, but as we do for individuals, depending upon the person's orientation and what and how the eating pattern is, that will inform our innovative ways of helping them achieve their sodium requirements. Okay, so that's what I wanted to add. Thank you.
Thank you very much, Adibedu. Before I take Safiano Osman's question, let me read. There were a few questions in the chat box that we have skipped. So the first question is, any thoughts on anemia and hypertension? Any thoughts on anemia and hypertension? And the second question from Adoma is that in Ghana, most of our milk is in the canned form. Is that a concern for reducing sodium in one's diet? So first, is any concerns or any thoughts about anemia and hypertension? And the second one is not a concern when it comes to reducing salt. It's in the canned form. All right, Lizzie, please, if you can take these two questions before we go to those whose hands are up.
Okay, so the question on anemia and hypertension. We know many patients will come in, they have anemia, and then the definition will be mini moja. And then they also have hypertension, and then they are saying that moja broso. So how can you have moja broso and then you still don't have moja? So yes. So these are things that come up every now and then. We get patients who have both anemia and then hypertension. But we are saying that help the hypertensive patients to eat the DASH diet way. The DASH diet includes good sources of iron that can also help with anemia. Lean proteins, poultry and meat in the lean meats have good amounts of first-class, and these are first-class proteins that have good amounts of iron. So that can help with the anemia issue. You also have vegetables, which include dark green leafy vegetables, from which we can also get iron. So of course, if you are doing the DASH diet, it is not just going to help with the hypertension, but all these food sources which are great for making the HB levels come up are also present in the DASH diet. So Yes, if you follow the DASH diet, you would be able to meet your anemia needs truly. And then again, it's always an individual affair. You want to calculate how much protein in there and how much iron you're likely to get from there to help bring the HB levels to control the anemia. Now, when it comes to the canned milk issue, the question was that in Ghana,
that's majority of our milks are canned. So is it a concern if we are looking at reducing the sodium content in?
So how much sodium do we have in the canned milk, and how much, by the way, are they consuming? And otherwise, you want to go for skimmed milk, which is lower in fat and it's also lower in sodium. You can use that. If it's a canned milk, I'm not sure I have much concern about it, except for the fat content and not really the sodium content, looking at how much they are having. And again, it comes to how much sodium you are having at the end of the day and not just in one meal. So if you feel that your milk is quite high in sodium, balance the other food substances so that at the end of the day, you are sticking to your recommendations in there.
Thank you very much. I think what all this is drawing my attention to, and what I would urge all of us is to be current with the things on the market. I think Adilise mentioned that we have low sodium canned foods and all that on the market. Some of us, let's try and do more window shopping to get to know what is available and what is not available. Let's not just stay in our consulting room and take out the Kobe, take out the money. Let's give them options. We only get options when we know what the producers are bringing on the market and we are reading. Our clients can read, some of them can't read the label. So we have to read and interpret that data for them. Thank you very much, Adilite. So now we'll take the next question from Safiano. Please, you can go ahead and ask a question.
Okay, thank you for the presentation and thank you for the opportunity. So my concern, it's more of a suggestion or a contribution. It has to do with how we monitor the management of hypertension in our clinics, specifically for clinical practice. So what I've observed over the periods is that we are some of the professionals are so inclined to taking it from a medical view rather than a dietetic view. This being saying that they always strive to resolve the hypertension crisis or resolve the blood pressure, which I think isn't really our domain to tackle from. So I see it from the view like we are talking about the quantities of sodium and all those stuffs are really what we should focus on. But we have a very big challenge as to how to always quantify and track the progress of the quantity our patients are eating is what is the challenge. So I see it in this view that you may give your intervention to the patient and the next day you would see that at the ward, the dietetic professional goes back to the ward and instead of monitoring the nutrient intake, that is what is the priority for you, say sodium in this case, the person goes back to focus and monitor on the blood pressure. That is quite not appropriate because in this case, just the intervention you gave the previous day, and when it comes to diet, you just don't get that change within a day or two. So when you come back, you realize that some of them will go back to the ward and their sole goal is to look at the blood pressure. They check and the blood pressure is still up. Then they quickly have to go and monitor. They quickly have to alter what intervention they gave again without any assessment to know whether your intervention was right from a dietetic viewpoint or not. So it's like we always confuse ourselves later on by trying to focus on or ignorantly focusing on the medical aspect, which is not usually our domain. You may give your intervention appropriately. You may give the nutrient intake fine. The patient is within the prescribed recommendation you've given. However, the pressure may be up. And in that case, that is not still a dietetic problem or something you need to alter. But what I've seen or observed over the period is that when they go back to the ward, it's always about looking at the blood pressure. Yes, you may look at it to just give a clue whether you need to do any changes, but that shouldn't be a reason to, because it's just a reason to alter your intervention without any assessment to know whether your intervention is on point or not. And I don't know if I've missed this, but the issue of MSG and hypertension, I don't know if I've missed it, or probably it has been spoken about. Maybe the presenter could just highlight what you'd say on MSG and the issue of hypertension. And lastly, I want to just touch on the concern that was raised on anemia and hypertension. So I think in this case, yeah, we of course would want to probe further to know exactly what is causing the anemia or what is causing both the anemia and hypertension, because you may have it in the case that it's a kidney-related problem. And once the kidney is having a problem, you are likely to have both anemia and hypertension coming in. And in this case, you may not be able to recommend a DASH diet, because the DASH diet specifically is targeted at hypertension only. And the food composition of this DASH diet is usually rich in potassium, and that is something you may be cautious in when you're handling kidney area. And recommendedly, according to the KDOKI guidelines, that's the Disease Outcome Qualitative Initiative, strictly when you have a kidney-related problem with hypertension coming in, you cannot recommend a DASH diet, because that would be a conflicting therapy you would want to give at that instant. You may want to look out for the Mediterranean diet or other healthy eating pattern in that case. So that's just what I want to touch on. Also, bring another view as in the anemia area. So if we happen to look at our FBC results and we realize it's an intake problem of iron, fine, that is it. I think that's cool. But we may have to also be wary and look out whether there's a kidney problem, so that you are not addressing one problem and causing another problem. But I would want to have a view of the MSG and hypertension if our presenter had not already touched on it. Thank you.
Thank you very much. Easy. MSG and hypertension.
Yeah, okay, so thank you for your contributions. The MSGs are typically in the artificial spices that I mentioned earlier. So if you are encouraging the clients to use the natural spices, and encouraging them to, you see, when it comes to this hypertension control, they have a lot of benefits when they are taking control of what they are cooking and eating. However, sometimes work and other stresses of life does not allow people to go that way. But the best option is to encourage them to cook and eat, monitor what is going in there. So if they're doing that and using natural spices and all of that, the MSGs are difficult to find their way in the food. Now, if they're buying food out there, there is very little control when it comes to what you're eating. There's no way you can reduce the salt or the sodium coming from MSG or actual salt in the food. So the best way is to encourage your clients or the patients to bring home cooked food to work, or if they can't do it daily, reduce drastically the frequency of buying wayside food, fast foods, and all of that have high amount of MSGs and sodium, which directly impacts on blood pressure by increasing it.
Thank you very much, RD Lizzie. I have a contribution here, but let's take Rita's question before we move on.
All right, thank you very much. Please, this is a bright idea. Just that I'm using different account, that's why the name is different. Please,
No problem, we understand.
Yeah, everyone. Since we are talking about hypertension, sometimes when it comes to clinical practice, you might have a patient or client referred to you by a doctor who is hypertension, low pressure. So in that instance, is it advisable for you to, tell the client to increase the salt intake so that it can increase the pressure a bit? Thank you very much.
Elizabeth, did you get the question?
So the question is on hypotension.
Yes.
Okay.
So is it advisable for you recommend or something. That's it.
Yes, you want to encourage them to take normal amount of salt and not necessarily high amount of salt to correct that hypotension, because I've dealt with a few patients that were originally hypotensive. Their blood pressures were lower when we started attending to them. And then the idea was to increase salt. They started eating the Kobe, adding a lot of salt at table and all. And within 3 to 4 years, when they came back and then we were checking blood pressure, remember that things are changing. Their age is going up. So if this is an adult, you don't want to encourage high amount of salt just to correct that hypotension. Of course, they may have to see their doctors to help manage that. But when it comes to diet, the intention is not to increase sodium intake excessively to make the blood pressure go up. They may inch it up a bit, but not excessively high to correct hypotension.
Okay, thank you very much. Before I think there's a very good comment from RD Divine in the chat box, so we all can read it. It's a very good contribution. I have I don't know whether I should play the devil's advocate, but Safiano mentioned something about we focusing more on the blood pressure readings instead of the nutrition interventions that we put in there. I don't really see a lot of adults, so I may not be very knowledgeable in this field, but I want to find out from my colleagues and senior people on this call whether it is totally so that you should not focus on the blood pressure readings, because I feel if I put in an intervention, maybe I do a sodium of 1,005 milligrams, and then I come and then your blood pressures are not correct and then they are still going high. That should tell me that there's something going wrong with my intervention. It's easier. I think it is easier to look at the biochemical data instead of going to do an assessment on how much sodium the person took for, let's say, the past 24 hours. I don't know what others would say about it, but I don't think we should totally not look at the blood pressure readings. I think you should look at them. Then that would help you also make an informed decision, because you can be doing, or the patient could be taking the recommended sodium he gave, and the rest may still be going high. In that case, it sort of no longer becomes only a nutritional problem, but then you should alert the physicians. Maybe medications are not going well, because it's a teamwork. So if you decide not to look at, or you don't give, I don't know, much priority to the biochemical data, I think it's not in the right direction. If anyone has something different to say about it, yes. So I think Safoyan has raised up his hand again. Maybe please, you can go ahead and.
Okay. Thank you. So I think that's exactly what I was trying to communicate. So the point is that despite the case of the pressures being high, we have recommended amounts when it comes to the intake. So once you are doing that and also watching the blood pressure, so let's say I do my intervention of 1,500 milligram of sodium, and I realize that the patient is taking this within range. Ideally, we would have done a nutrients biochemistry to know how much sodium is actually in the blood, but that's not possible usually in our case. So the next point is always to alert the physician to also have a second look if there are other causes of the blood pressure, because it might not always be the intake as our people lately we see. Once there's hypertension or diabetes, it's dietary related, and that is not always the case. So the idea was that once you give your intervention, you monitor to see if they are actually okay, looking at the blood pressure as well. You have to do that. But when you realize that your interventions are okay based on the blood pressures, you realize the therapy you are giving is not faulty, everything is okay, you now have to look at the physician aspects. But what I have noticed from my various rotations is that you would have the patient, the physician, the dietetic professional come once they pick the blood pressure readings and they are still up, the next thing is to alter the intervention, which is not usually the case. So the idea is that you make sure that your intervention is on point or not, because intake of sodium doesn't necessarily would make your blood pressure go up. So you'd always have to be wary, like you've raised it. That is exactly what I was trying to communicate. So once we put in our intervention specific, I don't think we have any recommendation usually below, let's say 1,500 or way below 1 gram of sodium in a day. So if those are within ranges, you see that the patient is eating well, diet-wise is fine, and the pressures are still up, you shouldn't still want to restrict or modify the person's dietary aspect. It should now also be the point that you give a call to the physician to have a second look, or tell the physician you think the intake problems are okay, because that is specifically what the dietitian should be doing. So you think the intake problems are okay, but pressures are not resolved. He may have a second look at it. There are other medical causes that you may suspect. So that is what I was trying to communicate. Because I realize mostly we make the medical views or the medical aspects, and blood pressure is actually a medical aspect. They will make them influence our decisions quickly, and I think that shouldn't be the case. And for the MSG issue, I wanted to know if we have some data on, because I see that per my readings, and currently we are doing a systematic review on it. We are still yet to come across RCT's clinical trial systematic reviews on the issue of MSG and blood pressure, because in the history of the MSG, we noticed that these products were actually developed to help manage hypertension. So if you pick an MSG product, and specifically the sweetness you are getting from it is as a result of the glutamate component attached to the sodium. So, but we have a notion that once we have, sorry, I'm not referring to the professional, but the general public, once we see something sweet, or the notion of artificial sweetness, then we automatically tag them. And as bad. And I think from a professional viewpoint, we should not too in that lane, because the evidence we are seeing impacts. So the problem would come from people using this energy in addition to salt, in addition to other processed foods, which cumulatively will make the sodium levels go up. But it's not always the case of the monosodium being the problem. So ideally, it was even recommended that when people are taking out their sodium from the diet strictly, they could even replace with the monosodium to keep the food or enhance the flavor. So that was the goal of this product being developed. But I think we are using it wrongly, and not actually the product being bad. So maybe I think we could pick it up and look at more information on it. Thank you.
All right, thank you. I think that was quite an elaborate point with a few things to look out for in the future. Maybe we can see if we can gather data, do another CPD sometime in the future about MSG. All right, Ardi Hamda, please go ahead and ask your question.
Hello.
Yes, please.
Good morning, Noble. Good morning, Noble RDs and Noble RMs. Thanks so much. Thanks so much for the insightful presentation. Mine is not a question, but I just want to a contribution to the hypertension management. I just want to add whatever on. Monitoring is key, as it has been said over and over. Some of the things that has really helped some of our clients and myself personally is adequate hydration. When it happens that we will have to reassess our clients and see whether they are adequate, they are really hydrating adequately. So that is one aspect. ORS also helps a lot when you are trying to boost up the BPs. And then, of course, our coconut juices. So as it's all about ensuring that your client is hydrated well. And then if there's any underlying condition, whether medical or surgical, again, it is a multidisciplinary approach to management. As it was said earlier, you have to discuss it with the doctor who referred the patient to you, and then together you'll be able to get a holistic approach to this. So our own home therapies helps a lot. So this is the little that I have to add to clients who have hypertension. Thank you.
Thank you very much, Claudia Hamda, for your contribution. I think we'll take the next two questions or contributions, then we call it a day for our CPD. RD Beidu, please go ahead.
Okay, so I just wanted to make a comment on RD Safianu's contribution. So we must not look at it as either or. So it's not either the blood pressure is coming down or going up. No, we have done enough for the patient. Both of them work in tandem. So in most cases, it's only on a few occasions you will be managing a hypertension case with very good DASH diet. You are giving enough fruits and vegetables. You are managing the salt, and the patient is still not doing well. I think it is a dictum for all dietitians that you make sure you do what you have to do. So after you have gone and done all the things, you've given high potassium foods, you've given a balanced meal, you've done all the things, and the patient is still not doing well. Yes, you can't go beyond what you can do. Sometimes even the medical management, they also get to a place they can't go beyond what they can do. But then if we have to say the outcome of the pressure should not be, if I understood you, should not be our of utmost interest to us. But whenever we go for review, it must be about assessing whether our interventions are taken through. That would be stretching it too far. It must be side by side. You look at the pressure levels, you look at your interventions. Sometimes you realize that even what you thought you have done, when you actually go and interrogate, the person might have even eaten from another source you were not even aware. So both must be looked at critically, not only one. If we do that, we'll better serve the patient than saying that mine is the diet, mine is to assess the diet and see the others should be handled by the other people. No, all of us work together. And if the diet and the person is on a medication and it's actually helping, both work together to bring the pressure down. So on one or two occasions, if it's not coming down, you know that you've done your best. But it shouldn't be in all cases. Put all together. When I go, let me put this one. The pressure is not really the case. No, that one would have been working halfway. Yeah, and with the MSG, as you rightly said, we cannot say it helps or it doesn't help because the data is not there. Now, if we don't have very sound data to do either conclusions, like the evidence tree we looked at last week, expert opinions are also important. So for those of us who have practiced for some time, you have a lot of indications from the consulting room. They will tell you, whenever I eat and I put this thing in, I have palpitation. So that there are things we have, experiences we have garnered over the years of practice. So whilst we wait for RCTs and we wait for proper analysis, meta-analysis to be done to come to a conclusion, we must not ignore the experiences we have garnered over the years concerning what the impact of this has been on people, right? Apart from that, also the basic chemistry behind it. If it's monosodium glutamate and compared to the sodium chloride, you know that sodium chloride does not, will dissipate easily and will break easily into the blood. If it's monosodium glutamate, which is coming from a weak acid, you are going to have prolonged breaking point. So if you have to, we have to gather all this knowledge together to make a point, right? So that we don't say, oh, it doesn't matter, you can add some to the food. And you will not say how much the person may even have to add and how much of sodium chloride they must have to take away. So we must look at the people we are managing, what they are actually taking. If they are taking all their food from outside, you know that monosodium glutamate is in their food already. If they are cooking themselves at home, you ask yourself, what will you give to your clients? Sodium chloride or an MSG? So that decision must be made. And whichever decision you make, it should go towards the point that the sodium content of the food must be within your limited calculated amount. Thank you very much.
Thank you very much, Adibe. So I think at this juncture, we have confidently dissected hypertension management from our resource persons to the expert opinions, to the contributions, to the questions. We are very grateful. Thank you all for contributing to it. Before we end today's presentation, like we said, we have just a few more minutes, about 30 minutes to discuss a few things about it. And I indulge each and every one of us to be involved, at least if we don't have a full meeting today, we can start something to move on or continue from there. So at this juncture, I'll thank you to RDC and then everyone else. We'll do proper vote of thanks at the end of the meeting, and I'll hand over to the president of the Southern Zone GAND, Mr. Haruna-Zeyi, to take over from here. Mr. Haruna, please over to you.
Good morning to you all. Please, can you hear me?
Yes, please, we can hear you. Good morning.
Abdullah, I think I will still have to come back on you. This president, I've told you recently, it's difficult to call yourself a president too. So just call me.
Sorry, sir.
They'll come after me. All right, so the attendance today and the level of participation by members. This goes to demonstrate the fact that we are poised in making changes and making an impact in the in our various work sector and towards the good well-being of Ghanaians at large. I must also commend Adibedu and Adia Hamdaratu for their immense support for all this session. The Southern Zone is actually endowed with a lot of human resource base. And I feel that there shouldn't come a time where we'll find ourselves wanting as to how to get people to help facilitate programs or to support us in the organization of events. I will not talk much since we'll be having our meeting shortly after this. I want to also just say thank you to all participants for this session and hope that what we have learned today will go a long way to assist us in our line of duty. Thank you. So my boss, Abdallah, can we go ahead and start the meeting or there's another agenda?
Yes, sir. Yes, please, you can.
Okay. Do you have the agenda for the meeting typed out? Yes,
I can.
So I will just project.
I'm just okay. It's just a minute. Let me put it in the chat box. Okay, so please, it's in the chat box. Since this is our first official meeting, we want to do a sort of introduction. Not first official.
For the purpose of the introduction, I will urge the executives present here, the servants present here to on their video so that members can have a look at our faces to see, so that when you meet us anywhere, you know that these are your servants. You can easily send them around.
All right. So I think the next person is Dr. Hayford. I don't know if he's still on. What's this? We can go on. I think Dr. Hayford and the rest.
So I have myself. I'm a public health nutritionist, right? But I currently work with the Council for Scientific and Industrial Research, biomedical and public health units, and also double as the administrator for the Institutional Review Board for the entire institute. So my office is located at Airport Residential. Anytime you are in and around that area and you want to see your servants, I'm around. You can pass through. So for the purpose of the Southern Zone, I am the chief servant for the zone. So with me is Abdallah. Please can you introduce yourself?
Yes, please. My name is Abdallah, a dietitian at the Princess Mary Louis Children's Hospital, and I am the organizer for the Southern Zone camp. I don't have a long profile like Harry.
Okay. So we have our secretary to be Mamiesi, who is currently not with us. We also have Dr. Hayford, who is deputizing as our deputy chief servant. Then we have Thelma, who is supposed to be in charge of mobilizing the small coins we can also find around to support us in carrying out these activities, various activities that will benefit the zone at large. We also have some cooperative student leaders of the various blocks. That is the Dietetics Student Association and then the Nutrition Student Association, both at University of Ghana. We also have them on the committee. We are trying our best to ensure that we bring all these people together to get to work effectively for the zone. If you have them on the online, please can you on your videos and let members see you? Abdallah, do you have them online?
The student body. Amanda, are you here? Louisa, I think Louisa was here. Louisa, are you still here?
Please, Louisa, if you are here, kindly on your video so that they can see your face.
Amanda, if you are here, please raise your hand so that I can give you access to unmute and show your video too.
So once we are waiting for them to show up, we'll move to the next, which is the purpose of the Zoom. RD, Hamda, will you take us through that, please? Adia, is Adia with us?
Let me unmute. Yes, here. Ariamna, please, you can go ahead to unmute.
Okay, so if she's
Hello. Abdallah, please, the line wasn't clear.
As part of the agenda, we want to inform members the essence of having the zones as part of GAND. And we wanted you to do us the honor by talking to our purpose of
Zaid, I'm having some network challenges. So,
right.
Hello.
While Ajay is sorting out
Please,
the
we can hear you.
okay, so
We can hear you already, Hamda.
Abdul, let me continue. So, okay, so
Yes,
GAND
please.
sees and recognize the fact that the country is a large territory, and for that matter, we need to be able to and get in touch with all our members across board so that we can serve their needs and also contribute to their professional development. But due to the vast nature of the country or our locations, it was prudent for us to be able to segment or divide the country into zones so that we will be able to attend to our members wherever they are. So for the southern, we had different zones that were created for which we fall as part of the southern zone. The southern zone, which is made up of those of us in Greater Accra, we mainly constitute the southern zone, and our role is to contribute to the improvements and functions of NEC or GAND in general. And we can only do so by getting in touch with our members, organizing programs that are beneficial to our members and can support the professional development of members. Abdullah, if you have something, you can also add.
Yes, please. You said it all. So we are looking at the professional members, the academia, the students. So the southern zone is basically the zone for all dietetic and nutrition students, all dietetic and nutrition professionals, and all of our colleagues in academia. So it's just Greater Accra. I think we are a lot if we all come together to help GAND progress and then move forward in this country. So yeah, I think that's what I'll answer.
So we'll open up for members to ask questions so that we can move to the next stage. So from the introduction to the purpose of the zone, if members have questions, please kindly unmute and then ask your question so that we address that one before we move to the next one. We are to try as much as possible to keep the meeting very short so that we can all return to our various huge points.
Please, you are able to unmute now. So if anyone has a question, kindly go ahead and unmute. Or you can equally type in the chat box.
Eunice, I thought you were going to ask a question. Eunice Beku. All right. So if no question is coming up, then let's move to the next itinerary on the agenda, which is our meeting days. Now, it will be good that as a zone, find time to be able to meet, share ideas, deliberate on issues that are emerging, and also find different ways to plan for the future or the next period session. So at the executive level, we try as much as possible to have either Zoom session meetings or call-in session meetings where we deliberate on issues before we put it before the members. It would be good if we are also able to have such meetings among ourselves as a zone. So we will open the floor for members to make suggestions as to how often should we be meeting as a zone and see how we will be able to deliberate on some of these issues. Abdullah.
Yes, please, I'm here. Hello, GAN members, please share your suggestions and let's move on.
Please, like I indicated, servants, we cannot work if you don't give us suggestions, and we are there for you. And it's because of you we are here. If you don't give us the suggestions and the guidance, we will not be able to deliver to your best satisfaction. We want to also make you happy. We want to be able to meet your needs, if not fully, but halfway. So kindly give us suggestions so that we see how we can work around it. We have had planned sessions that we'll be having meetings with the student groups to hear from them what their concerns are and what the possible thing can be done to support their cause. So for the zone members, if you let's hear the suggestions. We meet quarterly, we meet monthly, we meet half year or annually. Let's propose. Hello. Will I begin?
Hello, please. Let's.
Okay, so
Okay, someone suggests that since we have CPDs that bring us together, we should meet annually. That's some suggestion. Anyone else with another suggestion?
That's a nice. Someone has also suggested quarterly.
Hello.
Quarterly. Yeah.
Hello, I have a question.
Go ahead. Okay, sure.
I want to find out whether you're referring to in-person meeting or virtual meetings. What kind of meetings?
Okay. So the question is whether.
Hello.
Anna, please go ahead.
Okay, so it is left to us as a group to decide whether we want an in-person meeting or Zoom meeting. But I would love in the near future where we'll be able to have in-person meetings or in-person get-together sessions to get to familiarize ourselves with ourselves and then also to create further networks. So it is open to the board.
Okay.
The zone decides we want in-person meeting. Our job is to make sure that the in-person takes place.
All right. So I also have a suggestion. Okay, so I'm also suggesting that currently we are doing a mixture of in-persons and virtuals. If possible, assuming we agree on, say, quarterly meetings, can decide that the quarterly meetings would always follow an in-person CPD, so that we know that maybe for a quarter, in every quarter, we have one CPD that we are going to do it in person, and it is tied to our zonal quarterly meetings. That is if we agree. So we can agree that whatever period we choose, that meeting would be an in-person meeting coupled with a CPD to make the day more fruitful. So that is my suggestion as well.
That's a nice one. That's a nice one. Any other suggestion? RD Prince Bedu. In fact, you are my boss, but at this moment you are a member. Please kindly give us your suggestion.
Okay, President.
Yeah.
Chief servant.
Yeah, chief servant. I think for me, as a son of a poor cocoa farmer, what can I say? Whatever we agree, we come to, I will concur and abide by. But I think so far the suggestions coming are fine. Whatever we conclude on, I'll move by it. Thank you.
Thank you. Okay, so I think I will have to start mentioning names at random. Is Madame Georgina with us? Madame Georgina, please, what's your view regarding this? Madame Georgina. Madame Irene actually with us. Madame Irene, please.
Please, the students and the interns, please, you're also involved. You can share your suggestions. Students, everyone.
For the students and interns, know that we have all the big men and big women on the platform. If you don't talk, they don't get to know you. Please talk. And request for them to show their faces so that you know how to look for them. Madam Grace, are you with us? Please share your view. Okay, so there's another one saying annual, another one is saying that biannual is impossible. Okay, there is a hand up. Abdel, can you unmute the person?
Adi Maxwell, go ahead. You can unmute.
Yeah, I want to thank the Southern Zone committee members and executives for the great sacrifices and the work that you are doing. I must say that you guys are really doing your best. So with regards to the meetings, when we look at the allied health, the CPD requirement, it means that basically every year we're going to have a lot of CPD meetings. So I don't know. I mean, the suggestion in kind of integrating the meetings with the CPDs, I think is on point. But the other thing we may want to look at, I mean, how often do we have meetings aside the CPD? So I think if we want to have the quarterly, that's okay. So this is my suggestion. So we'll have quarterly meetings, which will be kind of linked up to our CPDs. But out of these quarterly meetings, we can do a one-time in-person, given the fact that the conference of dietetics and nutrition would also be done in person. So at least in a year, if that conference is coming on and it's in person, then we can also have one in person. So our meetings will be quarterly, which is, so the other two other meetings within the quarter could be more of an online, and then one in-person meeting. Then the conference meeting will add up. At least two in-person meetings in a year, I think is fine. Because looking at the current situation, I mean, COVID-19 has come to show us that there are other options. And I think members have been so used to the online that even now organizing an in-person is a problem. So we could start gradually with the one in-person on quarterly basis. Then the other ones will be maybe a virtual meeting. Then the conference one, which is in-person, will add up to at least, and that will be two in-persons in a year. I think that will be better. So that's my suggestion.
All right. I think it's a very good one. Aruna, please, can we proceed?
So that's a nice suggestion by Mr. Maxwell. Should we move on to the next one?
Yeah, I think so. We have the quarterly fused with the CPD in person, and then we have the annually. Biannually, I think would more or less sum up to what RD Maxwell is saying. So maybe we'll choose between, or would look at it between the annually and then the quarterly as suggested, and then get back to the zone.
So that those in favor will show by hand.
Okay.
The voting.
Please come again.
Abdullah.
Yes, please. Please come again. You said something.
Let's put the two suggestions to a vote so that we select one. Then we know that on this particular topic, we have selected one particular suggestion.
Okay, all right. We can move on. Whilst I work on that, I'll probably put it in the chat box so that. Please, we can move on so that I work on that as well. Rona, Hello, Aruna. Hello. Okay.
Abdullah, so I think you can go ahead.
Yes. Yeah. So the next thing.
So what's the conclusion on the first one?
So we are to vote between quarterly and then annually. I'm trying to see if I can start a poll on the Zoom right now. But whilst I work on that, or maybe we can do that on the WhatsApp page when we leave this meeting so that we can conclude there. I'm not host currently, so I don't have all those privileges of using the board or something. So please, I think we can continue then. We do the voting on the WhatsApp platform. So the next thing on our agenda is the plans that we have or we want to in place. So currently, the kids executive board is an IMC sort of that came up for the rectification of the various zones. I think in the very near future would be glad if together with the general board, the GB of GAND will organize a well-defined elections, nominations and elections for the Southern Zone so that we all can, I know there are people who are interested in serving the zone in various capacities, and it will be very needed for us all to come on board. So one of our plans is to get the people come on board. We have to get an executive committee, so nominations and elections will come up. Everything related to that will come up. Also, we have to get committees, subcommittees working to help the zone. So we'll need to have an organizing committee to help with the CPDs. We need to have other committees that would go to our various colleagues in the various facilities, a sort of monitoring, familiarization with everybody in the zone. And then as well, we are looking to incorporate, as we have started already, the student membership body in terms of both the dietitians or the dietetic students and then the nutrition students. So we have been able to meet with the dietetic students. We have planned a meeting with the nutrition students, and we are looking to bring everybody on board to augment the whole zone because they all make up the zone. So these are some of the plans. We are open to more suggestions from all of us. If we have any to help the zone become better, like I said, this is an IMC, and those of us who are interested in serving in the various capacities will make that known, and then how best we can go about it in the shortest possible time. So that being said, I think the final thing we would like to do is just to open up the platform for everyone. I think a couple of people from my engagement with some people don't really understand what the whole zone is about, don't know how things are supposed to be. So if any of us have any comments, any questions, I think both GB members are here, local executives are also here. We'll see how best we can attend to them. So it is time for open forum. So if we could share our views. I know some facilities, some colleagues don't understand why we should join the zone or how the whole zone now then is coming up. And this is our chance to talk about it. So if anybody has anything concerning the zonal formation, concerning the CPDs, concerning the subscriptions, concerning the payment of dues, everything at all. Currently, we are going to act as a liaison between the Southern Zone members and the GB. So If you have any concerns concerning the CPDs, concerning the registrations, anything at all concerning GAND, please feel free to unmute yourself and then talk about it. Thank you. So the floor is open, please. Please,
Yes,
the
hello.
floor is open to us. Hi,
Hello.
Dorothy.
Yes. So my question is about the CPD subscription. So earlier, there was a deadline and then an amount of 200 cedis for the CPD subscription on the Telegram page. But then later, there was something about 500 cedis. So I wanted to find out if you had already paid the 200, doesn't mean you have to top up, or the 500 is for a late payment or something.
Okay. Please, is that all?
Yes, please.
All right. Okay. So the 200 cedis bulk CPD subscription was a sort of early bird, something that the GB introduced. So everyone able to pay that 200 cedis subscription was entitled to having all the CPDs in the year for free if you are in good standing, meaning if you have paid your annual dues. So in that sense, coming June 30th is the end of the registration cycle for GAND. So if by June 30th you are in good standing with GAND in terms of membership, you have paid your membership dues of 240 cedis, then the 200 cedis holds for you. It means that you just need to pay the 200 cedis which you have already paid, and you would get all the points for all the CPDs you attended. On the other hand, if by June 30th you didn't pay, if by June 30th you hadn't paid your membership dues, so July 1st comes and then you haven't paid your membership dues, then now your 200 cedis no longer covers the whole year CPD, but would only cover for a couple of them, I think about 4 of them. In that case, you have to top up 300 cedis to make up the payment for all the CPDs, or in that case, your CPD subscription now becomes per attendance. So if by 1st of July you haven't paid your membership dues of 240, then the secretariat will look at it, how many CPDs you have attended. If you have attended 4, then you get the point for the 4 because your 200 cedis covers that. If you have attended more than the 4, you would have to pay 50 cedis per CPD for the ones that exceed the 4. So if you are in good standing, you have paid your membership dues of 240 and you have paid your subscription of 200, then you don't have a problem for the rest of the year. But if you have not, then you have to make sure you are in good standing to enjoy that 200 cedis, or you pay 500 cedis, that is 50 cedis per CPD for the rest of the year. And then that letter or communique that came out for the 500 cedis was to assist our colleagues who would like to make a request to their hospital. So the 500 cedis was for the whole year, you paying it CPD by CPD because you missed the early bird registration of 200 cedis. Please, does that clarify it for you?
Yes, please, it does.
Okay, thank you very much. The deadline for GAND membership payment is 30th of June 2023. Our registration cycle ends on the 30th of June. So latest by 30th of June, we all should have paid our membership dues of 240 cedis. If you have paid already, you are good to go. You enjoy all the rest of the CPDs, provided you attended or you watch the recordings and put in the attendance sheet. It is very important as well. All right. Any other question? You can type it, you can unmute yourself and ask. It is 12. If we can be quite forthcoming about this session so that we can end our meeting for. Any other question?
a question on when the deadline for GAND membership payment. I think that is still open, but left to me, I would have wished that we say right now so that people will pay right now. For the house to move or for the professional body to function effectively, to require us to be able to be committed. Our commitment in paying the dues would help move the association or the body or society forward. We cannot do that if we don't have funding. I would have loved that these CPDs that we are organizing, organize them for free for our membership. But here's the case, we are still cheating. We don't have the resources to do that. So moving on in the near future, we'll be looking at how best we as members can rake in other forms of revenue, be it sponsorship or other packages to help reduce this burden. I know now it's very difficult to come by money now. Everybody is hot, every package is dry, but we need to sacrifice or do something to support the body to function effectively. I will be taking your thoughts on some of these areas as to how best we can get funding so that we can take care of these CPD payments. Ideally, I wouldn't be happy to see members pay something like that. But if we have enough sponsorship coming from elsewhere, we could have taken care of some of these things. If even they have to get together. So let's be thinking around it to see how best we can move beyond this level. But let's start by being committed, by paying our dues.
All right. Okay. There's a question about how about the dues for students and intern. So I shared an information with that in 2021 and 2022, I have passed their licensure or have not been inducted by GAND. They are still students. So students are to pay 60 cedis as membership free of CPD. So all you need to go to everything that a professional member is entitled to. So you pay your 60 cedis before June 30th or as possible, like Haruna said, and then the rest of all the CPDs you have ever attended for this year or will attend will be free for you. So students are to pay 60 cedis, as well as members or interns who are currently doing their service, those who graduated in 2021 and 2022 who have not been inducted by GAND. All right, thank you. And the next question is, if you were inducted into GAND in November and paid your membership in full, does that mean that come June 30th, you would have to pay again? No. If you were, hey, please hold on. Let me seek clarification. So if you were inducted in November, possibly you became a member. Adibedu, please, can you help me out here? I'm not too sure of how to respond to this. Hamda. Mame, if you're here. Those that were inducted in November last year, I am not too sure when their registration or their membership starts. The membership, if it starts in January, then you don't have to pay. Yes, boss. Yes, boss.
Yeah, so it's within the GAND year. So that will expire in June. So if they paid their membership dues in November and they were inducted, the requirement to be a member is to pay your full dues at the time you are applying for membership, right? So that was a requirement for them to become members. Then they can take advantage of the 200, because as far as it is now, they are full members because they are paid up members. Yeah, so if they are paid the 200, that's all. But from July 1st, then our new this thing begins. July 1st. Yes, then they have to pay. Right. So they have to pay the new 240 for the next GAND year. But what they are paid now can help them to enjoy their 200, the benefits of the early bird.
For the rest of the year.
Yes, for the CPD.
For the CPD, yes, please. Yes, please. All right, Dorothy, does that answer your question? Okay. So the next question is, please, does the 60 cedis apply to students at all levels, including graduate students? How do you read?
Yes, if the graduate student is not a professional, a registered member already. Okay, so the graduate student is a nurse or a chemist, or by chemist who is coming to do dietetics, and it's not an RD. Yes, the person qualifies to be a student member. But then if the person is an RD who is doing a master's, the person is a full member, so we'll have to pay the 240. Yeah.
All right, okay. All right, thank you very much. So the membership is paid by mobile money or by deposit into the Academy's bank account. I would share that on the Southern Zone page. I'm coming to share the link for the Southern Zone for those of us who are not on it, so that we can have some of this information available to you. So I've shared the WhatsApp link for the Southern Zone. You can pay via Momo. You can pay via the GCB account of the association, of the academy, sorry. Please, any other question? Hello, Jane. Do you have a question for us?
No, please. Sorry.
Okay. Any other question? Any other concerns? Are RDs and RNs, do you have any concerns, any questions that we can address here? If not, you can always text any of the GB members, any of the exec. I don't know, please, can you take over?
Hello.
Yes, please.
Right. All right. So I think we are progressing, but it looks like
yes,
are not talking. I would have loved to hear Khadija speak, Abigail Usua speak, Mami Efia speak, Regina speak, Derek Odro speak, Esther Ahuma speak, Mauli. We are not hearing. There's another one by name Techno Spark. Hey, hello, who is this? Please, can you talk to us? Then Laura, let's talk among ourselves so that we'll be able to understand what is happening. And then another key challenge I'm looking at is how are we able to mentor our people within the zone, more especially the students, those who are who are graduating, and those who have written their licensure exams. I know we have our senior men and women on the platform. As a matter of support for the zone, it will be good. We try to have one session where we identify ourselves to be in position or be ready to take on some of these students and mentor them, because a lot of them have come out and they are still in the limbo as to what is expected of them as either dietitians or nutritionists, even though they've gone through the mill, but they need that professional guidance and mentorship. So moving forward, we'll be looking at some of these things to see how best we can help improve the professional strength of our members. Please, the floor is still open. Let's hear from you, Christiana. From Frank Marfo, let's hear from you. Hello.
Please, let's talk so that we can make progress. We have made a lot of progress. For now, we we have to do the poll on the WhatsApp page so that we know when we are meeting.
Okay, so I think that members are not having any further comments because it looks like the whole place is silent. Asiedu, if you have any suggestion or statement for us before we call the meeting to an end, please kindly unmute and then share your thoughts with us before. Abdullah, do you have any other thing that we need to look at?
No, please. I think we have not gone far, but it's okay for our first meeting. Hopefully, members will open up in a subsequent one, so it becomes more engaging in the coming days and weeks. So I think I don't have any other thing to. Our doors are still open to you. If you are shy or you would like to text us or call us privately, please. Like my boss said, we are the chief servant, so we are there to listen to you and to serve you. If any one of us have any challenge at all with regards to GAND or anything GAND can help you, please do well to reach out to us. Thank you.
Abdullah, have you noticed something?
Yes,
we have magically transported the silence on the platform onto the meeting platform.
We'll find a solution to it.
It looks like our platform is very. There are so many nutrition and dietetics issues going on in, more especially in the capital city. Let's talk among ourselves, be it on the platform or at meeting levels. Let's look at of addressing them. We can also equally write grant proposals to embark on activities that will inure to the benefit of the profession. So once we are in our line of duty, we identify certain challenges or areas. Let's put the topics, let's put them out so that we develop good proposals, we can seek funding, and then we do these works. It could be an advocacy, it could be an implementational study, it could be an intervention, it could be anything that we think can impact in the lives of our people in Greater Accra. Let's talk among ourselves, let's bring down the teething issues. What are the challenges at the market centers, at homes, in the vehicles? Are people still eating the junk foods in their vehicles? How do we help reduce that incidence that is leading people to our hospitals? How do we prevent it? How do we take care of, manage some of this? Let's talk among ourselves. When we see these issues, bring them on the page and let's share ideas. Probably you are managing a condition that is trying to be difficult for you. Bring it on the page. We have senior men and women amongst us who can share one or two experiences that they have, and we will see how best we can resolve it together. So please, let's kill the silence on the platforms that GAND members find ourselves in. A lot of things need to change, and it will start with us if we want that change to be effected. So I think we will not call the meeting to an end. We will only adjourn the meeting so that we'll continue the discussion on the WhatsApp platform. If no other comments or suggestion or question from members, we will call for someone to lead us in a closing prayer. Since we started with with an opening prayer, anyone touched by God to lead us in a closing prayer. Abdullah, do you have any housekeeping you want to talk about before the closing prayer?
No, please.
Okay. So
no, please.
Prayer. Hello. We have 33 people. At least one is touched. The person should lead us in a closing prayer. Okay, so let's pray. In the name of Allah, most gracious, ever merciful. Praise due to Allah, the cherisher, the sustainer of all worlds. most gracious and most merciful, Master of the day of judgment. Thee alone we worship and thee alone we seek for help. Show us the straight path as we strive to make the nutrition and dietetic landscape of our country improve. Guide us through all the difficult challenges that we may encounter in the discharge of our duties. We have come to learn today. It is our prayer that whatever knowledge we have acquired today, we will be able to put it to good use. Bismillahirrahmanirrahim. Alhamdulillahi Rabbil Alameen. Ar-Rahmanir-Rahim. Maliki Yawmiddin. Iyyaka na'budu wa iyyaka nasta'in. Ihdina as-siratal mustaqim. Siratal ladzina an'amta alaihim ghayril maghdubi alaihim waladdallin. Amen. Without much ado, call the meeting adjourned for further deliberation on the WhatsApp platform. Thank you. Thank you all for coming.
Thank you, sir.